Yes, excellent. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. Good afternoon for the eastern part of the Middle East. This is Dr. Suhail Al-Rukin. I'm a neurologist and a consultant neurologist from Rashid Hospital, Dubai Health Authority. At the same time, I'm the president of Emirates Neurological Society. It's my honor to be moderating for this session today. As part of the activity that we had currently in the society. This is a multiple sclerosis update 2020, which is supported today by Novartis. It's my honor to go through the program and introduce our speaker for tonight. We will have Professor Robert Chen, and he's a distinguished speaker from the US, who's going to speak today about update in managing the MS with the new treatment that's coming in the field of MS. Then we will have Dr. Talib Mansour, who's going to be with us for the next 2 days. Dr. Talib is a neurointerventionist and neuroradiologist, and he's going to speak about MRI and MS. Tomorrow we will have Dr. Talib again, and at the same time we will have Dr. Muna Khawaja, who's the head of the MS chapter in the Neurology Society in the US, and she's going to speak about an interest area of using virtual field for managing and monitoring the MS patients during the COVID era. So we will start tonight with Professor Robert Chen. Professor Robert is a senior neurologist from the Georgetown Multiple Sclerosis and Neuroimmunology and the director of the center. At the same time, he's a professor of neurology at Georgetown University. I remember Professor Chen was in Dubai early this year before the COVID story started by 3 weeks. And we enjoyed his talk in Dubai during our Emirates Congress of Neurology. So I would like to welcome Professor Chen, and he can start his talk. Then we will have the Q&A before he leave us for another meeting. Welcome, Professor Chen.
Thank you so much. It's such a pleasure to be here. My only disappointment is that I couldn't come back and visit again because I had such a wonderful time. Seems like it was so long ago because, as you said, it was right before the pandemic, really. So we never would have imagined how things would change dramatically. I believe when I was there, we were talking about Siponimod. So we were talking about a oral therapy for MS, and just goes to show you how much things have changed because now we have a completely different treatment option to discuss. So let me try to share my screen. Hopefully you can see this slide. This is talking about maybe reimagining MS and how we're treating MS has changed dramatically over the past few years. And I'm going to focus a little bit on certain B-cell therapies. So when we talk about treating MS, not long ago, MS wasn't even treatable, which is kind of amazing. So when I was in my training, MS was not a treatable disease. And if you diagnosed MS, we would predict that you would be in a wheelchair within 5 years, typically. And so things have changed a lot, and we've had many different therapies that have evolved. Within the past, let's say 5 to 10 years, there's been the recognition that actually B cells play a role in MS, which is interesting because at first we actually did not think that was true. So if you look at an MS plaque, on autopsy, for example, usually we see T cells. So we see activated T cells in the plaques driving the inflammation. And so for a long time in MS, I think we just assumed that this was a T cell pathology, not a B cell pathology. It took a while for us to recognize that B cells do have a role. I think we all know B cells mature in the bone marrow. That's why they're called B cells, as opposed to the thymus, which is where T cells mature. They're in the periphery, and we usually see them in other lymphoid organisms or organs, or in the spleen, for example. So it was really, I guess, it took us a while to recognize that B cells had any role in MS as well. And it is now recognized that we can see activated B cells cross the blood-brain barrier their role is not crystal clear. And as you know, in progressive disease, we're finding B cell follicles, lymphoid follicles, and we can even find B cells in the cerebral spinal fluid. But again, just we didn't see as many as we saw T cells, and so it was really not something that we were focusing on for a long time. But we've now learned that there is an important role of B cells in MS. And when I was in medical school, I learned that B cells made antibodies. I'll be honest with you, that's basically what I thought B cells do. They make antibodies. Plasma cells, mature B cells make antibodies. But it turns out B cells have many other roles. So for example, in antigen presentation, so when your body finds a virus or bacteria, something, macrophages might eat up that thing, but then the pieces, the fragments are going to be presented to other immune cells to say, hey, what is this? Hey, what do you think about this? Oh, hey, I need you to go find this and attack this. And so antigen presentation is important. And we think that that is a role that B cells contribute to in antigen presentation, perhaps to the T cells, telling the T cells, this is what I want you to attack. And again, by mistake, attacking the brain and spinal cord. And then, of course, B cells can also release cytokines. And, it's really just chemicals, just release substances that increase inflammation to say, hey, we need to take this seriously. There's a problem here. We need more inflammation. And again, it's certainly useful in fighting infections, but when there's a mistake in autotolerance, as in MS, releasing these cytokines increases inflammation, which obviously is a problem. B cells do produce antibodies, again, may or may not have a huge role in MS, but that is part of what B cells do. And as I mentioned, we are discovering that there are collections of B cells within the central nervous system, actually, subpial, that may play a role in the inflammation we see in progressive disease. So again, we've learned that B cells do, in fact, seem to have a role in MS. Again, we did not appreciate that in the past. But that leads us to a potential strategy, which is to target B cells. And again, we don't want to get rid of all B cells. But when we talk about B cell therapies, really, in MS, we're usually talking about anti-CD20 strategies, meaning we're going to clear out specific cells. Of course, all immune cells, they just look the same under the microscope, but they're going to wear a name tag. They're going to have markers that tell us who they are. So cells that express CD20 can be targeted. And just keep in mind that this is a subset of B cells. So remember, stem cells in the bone marrow and actually progenitor B cells do not express CD20. So when we use an anti-CD20 medication, it doesn't affect the stem cells. It does not affect the bone marrow very much. And again, the other role of B cells, producing antibodies, plasma cells, which make antibodies, do not express CD20 either. So when you use an anti-CD20 strategy, you're not touching the plasma cells and you're not really affecting stem cells. So it's really the cells in the middle that express CD20, such as maybe the cells involved in antigen presentation. Perhaps the B cells that release the cytokines that increase inflammation. Those are the cells that are being targeted when we use anti-CD20 strategies. Now, we have several that we use. In the US, we have Ocrelizumab and Ophetumomab approved for MS, but all over the world and in the US, people have often used Rituximab off-label as well. All of these target cells that express CD20. So they're similar in that regard. And we know that Rituximab and Ocrelizumab are infused monoclonal antibodies. Both of those products are typically used by infusion every 6 months. As we'll see, Ophetumomab is a little bit different. It is administered subcutaneously and given monthly. A subtle difference among these molecules is that Rituximab, which has been around for over 20 years now and has been used in many different indications, as you know, is chimeric. So it's based on a murine antibody. And then we have this chimeric antibody, which is Rituximab, and then that was further humanized. And then I think most of you are familiar with Ocrelizumab or Ocrevus. And then again, now we have Ophetumomab, which is fully humanized. And again, administered differently. It's no longer an infusion. This is a subcutaneous injection. In the US, we just use an auto-injector and the patients will administer that once a month. Now, in terms of binding, again, you could argue, is this really relevant? But both Ocrelizumab and Rituximab bind to a similar part of this extracellular loop, a part of that CD20 marker. But Ophetumomab, again, our newer fully humanized antibody, actually has 2 binding sites. So I think of it, our children, if they're playing in the gym, they're playing on the monkey bars and they're holding on. I think of it's one thing if you hold on with one hand to the bar, you might have a good grip, but the grip is going to be stronger if you use 2 hands. And as a result, really, with Ophetumomab having 2 binding sites and really locking in, it actually binds more tightly. Actually, it's more avid in terms of its binding to CD20 because it has the 2 sites that it can click into. You'll kind of notice this because the dosage that's required of these medications is actually somewhat different. With either Rituximab or Ocrelizumab, as you know, we typically use hundreds to up to 1,000 milligrams in a given treatment if you're, let's say, using Rituximab, or again, 300 to 600 milligrams of infusion if you're using Ocrelizumab. As you'll see, when we use Ophetumomab, when we use the subcutaneous injection with these dual binding sites, the dose that's administered is actually only 20 milligrams. So we can use a much lower dose in order to achieve similar results. Now, another thing that I would kind of emphasize, and this sort of goes back to animal models, is does the route of administration matter? It's infusion, fine, we're familiar with that, but what's the advantage of subcutaneous injection? Why would that be useful? And again, keep in mind, think about what we're trying to do when we use a B-cell therapy. We're trying to target B cells, lymphocytes, which, as we mentioned, are typically in the lymphoid organs, such as lymph nodes and spleen. And so if we administer a medication intravenously into the bloodstream, we have to assume or hope that those antibodies will circulate and then somehow get into those other tissues. Whereas subcutaneous injections, actually, how do they distribute? They distribute through the lymphatics subcutaneously, and you could argue would be more directly getting to the target we're aiming for. And you can see this again in the animal studies. So if you look at this slide, you can see that it doesn't actually matter which molecule you administer. You can see that the distribution is higher whenever you administer medication subcutaneously. So you can see the orange bar, you can see Ocrelizumab, subcutaneously injected into mice, actually distributes much more strongly than when it's administered intravenously. Actually, Ophetumomab is the same. If you administer Ophetumomab intravenously, you don't get as good penetration as when you administer it subcutaneously. But then, so in the center, it's sort of interesting, right? Because we're trying to use Ocrelizumab in humans, but we use that intravenously. Whereas with Ophetumomab, again, the mode of administration is subcutaneous. And at least in animals, we see quite a dramatic difference in terms of uptake within the lymph nodes when we administer it in that way. Another phenomenon that is relevant is sort of repopulation, because again, when we use our infused B-cell therapies, we typically dose them every 6 months. So it's sort of, it has a long action. And so you could argue that's an advantage. But if for some reason you needed to stop the medication, or let's say there was a safety concern, you can see that the infused therapies last much longer, whereas the subcutaneous monthly injection, actually, you have more rapid repletion if that should be needed. So again, another difference between intravenous and subcutaneous. So if we look at the clinical trials, I have to say B-cell therapies as a strategy are highly effective. At least I'm going to say, in my opinion, we could debate it. It's probably one of, if not the most effective strategies actually at treating MS. Again, ironic, because we didn't used to think that B cells had a role in MS, but once we realized they do, it led to a very effective therapy. Now, is a summary of the data from Ocrelizumab, and in the Ocrelizumab trials, OPERA 1 and 2, Ocrelizumab was compared directly to beta interferon, specifically Rebif. And you can see the benefit is quite good, right? So in the 2 trials, what is this, 47% relative reduction in relapse rate, good response in terms of reducing disability progression, good response in terms of reducing MRI activity, even preservation of brain volume, all good results comparing Ocrelizumab to our baseline therapies, beta interferon, a medication that is commonly used. Some people call them platform therapies. But here we have clearly demonstrated that B-cell therapies are much more effective than interferons at suppressing relapses, preventing disability, preventing MRI lesions. Safety is actually also quite good. So it's interesting because many people reserve these high efficacy therapies, say, well, I want to try something different first before I go to high efficacy therapy. And I think usually the justification is thought to be safety, saying, well, I want to be safe. And so let me use something safe before I use something highly effective. But if you really look at the safety data, again, comparing Ocrelizumab to interferon, there's actually not really very much difference in terms of tolerability. In fact, the adverse event in both groups is about either 80 to 85%. It's almost identical. So, there isn't really a big difference between interferons and B-cell therapies in terms of adverse events. Now, if you try to break it down into more subtle things, you could perhaps see some subtle differences. But, you can look at these columns. If you compare Ocrelizumab columns to the interferon beta columns, the numbers are really quite similar. Some difference, I guess the biggest difference would be in infusion reactions. We know that's true. When we use B-cell therapies, we do have to pre-medicate because of infusion reactions. So when we use Rituximab or Ocrelizumab, we usually pre-medicate with corticosteroids, maybe IV fluids, antihistamines, antipyretics. So you can see that column is higher in terms of infusion reactions. But overall, actually, even if you look at serious adverse events, the percentage between the two groups is actually quite similar. Sometimes actually higher in the interferon group, actually, which is interesting, right? Serious adverse events were more common in the interferon group than in the Ocrelizumab group. All right, now, how about Ophetumomab? Because this was recently approved in the US and perhaps will be available soon in the Middle East as well. In the Asclepios studies, Asclepios 1 and 2, these are identical studies. And again, using an active comparator, not interferon. In this case, teriflunomide or Aubagio was used as the active comparator. Some people have debated why pick one over the other. What's the point of this is, well, we want the comparator drug to have some efficacy, right? I don't think we feel it's ethical to do placebo-controlled studies because we have so many effective treatment on for MS. We don't want to randomize someone to get no treatment for 2 years when we have so many effective options. But we also want the comparator to be blindable, right? We don't want a lot of side effects that would allow someone to know whether they're on the comparator drug or the study drug. So I think teriflunomide is a nice option. It's a pill. They're not going to be flu-like side effects. If you've used it, it's a fairly well-tolerated medication. So anyway, teriflunomide versus Ophetumomab, a double dummy. So everybody was taking a monthly sub-Q. Everyone was taking a daily pill. Obviously, the Ophetumomab patients were getting Ophetumomab monthly by sub-Q and taking a placebo pill. The teriflunomide group was taking Aubagio every day and getting a sham injection once a month. So very straightforward in design. Typically, as you would expect, younger patients with relapsing remitting disease, no significant disability in the sense of not using a cane or walker, but EDSS scale up to 5.5 with some recent disease activity. Again, very typical sort of inclusion-exclusion criteria for our relapsing patients. As you can see, as would be expected, a relatively young population, average age of late 30s, relatively low EDSS scores, average of approximately EDSS of 3.0. And again, women more than men, again, as one might expect. So jumping to the chase, and again, trying to keep in mind, all of these are independent studies, but again, this is Ophetumomab, B-cell therapy versus Aubagio or teriflunomide, which I think, again, an established MS therapy, I don't want to debate too much, but I think most people perceive it at similar level of efficacy to interferons and glatiramer, sort of our platform level of efficacy. So you can see here, 50 to 60% reduction in relapses. This is not 30% better than placebo, something like that, or 50% better than placebo. This is 50 to 60% fewer relapses on Ophetumomab compared to being on Aubagio, being on an approved MS therapy. Relapse rate was more than, reduced by more than 50%. Looking at MRI lesions, very dramatic response. And again, teriflunomide, Aubagio reduces MRI lesions. It does help people with MS, But when you look at gadolinium-enhancing lesions, above and beyond what teriflunomide could do, we're looking at 94%, 98% reduction in gadolinium-enhancing lesions, above and beyond what teriflunomide can do. If you look at T2 lesions, again, greater than 80% reduction in just accumulation of T2 lesions, above and beyond what another MS therapy can do. In terms of disability reduction, again, actually, teriflunomide had sort of as a claim to fame, it had shown an ability to reduce disability from MS in 2 different phase 3 studies. Many of our MS pills and our injectable therapies had not actually been able to do that. Teriflunomide definitively showed that it can reduce disability over time, and Ophetumomab further reduces disability above and beyond what teriflunomide can do. Actually, another kind of interesting metric is this concept of NEDA, no evidence of disease activity, meaning no new clinical relapses, no change on MRI, no accumulation of disability. A very aggressive goal would be to try to achieve no evidence of disease activity with our MS therapies. Now, you may remember when this term was first coined a number of years ago, based on using our platform therapies in the era of interferons and glatiramer, our baseline types of therapies. We were only achieving NEDA in maybe 15% of a really small minority of patients could achieve that. We used to say, well, it's very difficult to really control MS. Look at these numbers. You know, if you just take in the first year, almost 50% of patients on Ophetumomab had achieved that. But again, remember, you know, in the first month or 2 of therapy, if somebody has a relapse, you know, you could argue, well, maybe the medication hasn't fully kicked in. So really what's striking is look at the second year from month 2 to 20 or 12 to 24, when they've been on Ophetumomab, basically, you know, for that entire time period, and look at the NEDA rate. Almost 90% of patients in that second year had no relapses, no gadolinium-enhancing lesions, no new or enlarging T2 lesions, no increase in confirmed disability worsening. It's very dramatic. I mean, we did not know that we could achieve numbers like that. And so very dramatic signs of effectiveness. Now, again, safety, because again, why would someone not go to a high efficacy therapy? I think the main reason is, well, safety and tolerability. People say, well, I want to be safe, and maybe the patient doesn't need highly effective therapy. Maybe they have a mild case of, I could understand that logic. I think inarguably, B-cell therapies have been demonstrated time and again to be more effective than other MS therapies, frankly, dramatically so. But what about safety? Like, is it safe to use them? Now look at the adverse event rate between Ophetumomab and teriflunomide. 84% of patients had some sort of reported event in the Ophetumomab, and 84% in the teriflunomide. It's identical, really. How about serious adverse events? Not just any, random symptom, but serious adverse. We're talking 9% Ophetumomab, 8% teriflunomide. And it's really, again, the numbers are quite similar. Look down these columns and you can compare across whether it's headache, even upper respiratory infections. The numbers are very similar. Sometimes the numbers are higher in the teriflunomide group. Upper respiratory infections were more common if you were taking Aubagio than if you were taking Ophetumomab. So you can really look at these numbers. And again, of course, as maybe you would expect, GI symptoms and hair thinning were more common in the Aubagio group than the Ophetumomab group. So from a safety and tolerability standpoint, I think the B-cell therapies compare very favorably to what some people consider platform therapies. Now, how about tolerability in terms of tolerating this monthly injection? Because, with interferons, you have injections and you can have a lot of flu-like side effects. Maybe 1/3 of patients will have flu-like side effects. But, what's interesting is after the initial injections, it's actually difficult to tell who is getting Ophetumomab and who is getting the sham injection. The rate of injection reactions is so low after that first exposure to the medication. In fact, unlike infused B-cell therapies, Ophetumomab does not require any pre-medication. So it's one thing to talk about a once every 6-month infusion, but keeping in mind that we also need to pre-medicate with corticosteroids and antipyretics and antihistamines and do sort of a observation window after the infusion versus monthly sub-Q with no pre-med. So in the US, I don't prescribe any pre-medications. Patients just take they auto-inject the medication at home. It takes about 5 seconds once per month. So again, very different really. And again, to me, the argument of avoiding high efficacy therapies, I think we might need to revisit that idea if we have a safe and well-tolerated option that is also demonstrably more effective than what we've seen before. Now, how is it given? The titration is fairly simple. I've been saying 3, 2, 1. So you get 3 weekly injections to start out with, is sort of the induction, if you will, is the titration. So 3 injections 1 week apart. Then there's a 2-week gap, no treatment. And then from then on, 1 injection per month, basically. So that's the strategy. So it's very simple. And again, patients can do it at home. You can see in the label, the first injection should be performed under the guidance of a healthcare professional. In the US, we interpret this to mean that, we need to have shown you or instructions on how to do it. But especially during the pandemic, still our patients do it at home. Perhaps they've watched an online video for the instruction, under my instructions. But that does not mean that I have to be in person with my patient. So summarizing, just in terms of some safety issues, some people have asked about, well, what about the immunoglobulins? Even though B-cell therapies do not target plasma cells, we have observed with some B-cell therapies, if you're on them for a long period of time, we can see in a minority of patients decreases in IgG or IgM levels. And you can see in the trials, there were 14% of patients who showed a drop in IgM levels. However, as you know, probably with our other therapies, that's never been associated with really any increase in infection risk. So we see that, but usually we don't really act on that. What we pay much more attention to is IgG levels, which did not actually drop significantly in the Asclepios trials. Obviously, we're going to continue to pay attention to that. But again, from a safety standpoint, things have looked fairly encouraging. In the US, we do baseline immunoglobulin screening, and then there's no there's no schedule for treating, just really based on our clinical judgment. So really, in summary, what I would say is that with B-cell therapies, in general, we have highly effective and well-tolerated options to treat MS that are significantly more effective than some of the older therapies we used to use. With Ophetumomab specifically, we now have an option for anti-CD20 or B-cell therapy that patients can do themselves once a month, sub-Q. They don't have to travel. And again, as you saw in the data, safe and well-tolerated, which again, I think might cause us to reevaluate our thinking about when we should use highly effective therapies. And again, keep in mind other subtle differences. There's no infusion, rapid repletion, no pre-medication, just something that our patients can do themselves once a month to control their MS very effectively. So again, thank you for the opportunity to present these data and to at least maybe start that conversation about should we, reevaluate. I was very impressed when I visited that you have organized and you have these Menactrum's guidelines that sort of, in the US, we have no agreement on how to use different therapies. But I know that in those guidelines, there's a thought that, well, if someone has mild to moderate MS, you may go with one approach versus, someone with more aggressive disease. And I did notice that highly effective therapies were, that seemed to be reserved maybe for second line, third line. And I wonder if, as these new data are presented, if one might consider reevaluating that algorithm, because again, I believe the thing that drove that compromise was concerns about safety and tolerability. And as we move to medicines that are actually safe and well tolerated, but also highly effective, why would we not consider those as early as possible? All right, thank you.
Excellent. Thank you, Professor Chen. Very impressive data, very nice, very target to clear message why we are saving or sparing an effective medication with a less side effect till we fail the other medication. You got it? I'm driving my car. Don't take the good car. Try to take the other one till you have an accident. Then we decide to give you a better car. So a few things. When I look first to the title of your talk tonight, reimagining MS, I said, what new things Professor Chen is going to tell us? Very interesting what you said. a message that you gave is we didn't imagine that we could reach this level of disease activity control. That is very clear. When you mention about NADA, almost zero for 2 years with disability and motor function control, comparing the side effect with an oral treatment with almost better side effect compared to other medication. So revisiting our management protocol, as he said, is very important. Which patient should be on these medication? If you are sparing the brain tissue for a long time, I'm a stroke specialist, and always we are speaking about acute treatment to spare the brain tissue. MS is not an acute disease, but it's a progressive disease. So if I can prevent one lesion from happening, why not to do it? So let us go to the question, Professor Chen. A question from one of the attendees: what the main difference between the old B-cell therapy like Rituximab with the new one?
Well, as we tried to show, certainly all of the B-cell therapies, I think, have good efficacy because, as it turns out, depleting cells that express CD20 is a great strategy. But again, in my mind, what I try to remember is Rituximab, as an example, remember chimeric antibody, still reasonably well tolerated, but remember when we infuse Rituximab, whatever your schedule is, and many people have very different schedules, we almost always still have to pre-medicate. Patients require additional corticosteroids to tolerate the infusion, as well as other medications, antihistamines and typically antipyretics. Sometimes other histamine blockers can be added. At least in the US, Rituximab was not ever FDA approved for the treatment of MS. It's used for many indications, and I have used it off-label over the years, so I'm very familiar with it. Then we had Ocrelizumab, which is partially humanized, but still requires pre-medication. In the US, and maybe you will also do this, our FDA has now approved a shorter infusion duration, reduce the infusion duration by about an hour and a half, but we're still talking about 3 to 4 hours in the chair. We're still talking about pre-medication. With both of those therapies, again, they're typically dosed once every 6 months. The depletion is actually quite long lasting. So we could debate, is this good or bad? It's nice that it's long lasting, but also harder to reverse. And so now we're talking about Ophetumomab. It's like, well, gosh, there's another B-cell. Why do we need so many different ones? But I would emphasize this is subcutaneous and monthly, meaning you can self-administer this. You don't have to go to a hospital. You don't have to travel to an infusion center. You can just, as we used to do with interferons and glutamate, but just not as often, just once per month, self-inject, no pre-medication. And then for what it's worth, the data does suggest the B-cell repletion is a little more rapid. You do have to take it every month, but if there was a need to stop for some reason, the repletion appears to be more rapid than with the other one. So again, subtleties, I suppose, but I do think that it does suggest that there might be, you might factor that into your choice of B-cell therapy.
Excellent. Second question is, how about vaccination, flu vaccination, and the COVID vaccination? Is there any data about this in MS in general and with this new treatment?
Yes, a very important question, and one we're all obviously top of mind because we're all anticipating being vaccinated for COVID-19 as an example. Well, so we have very limited data. We typically recommend, if you are pre-vaccinating, if it were to be a live vaccine, we would really try to do that, at least a month before receiving a B-cell therapy. A non-live vaccine, maybe at least a couple of weeks before treating. However, we don't really have guidelines for what if you are already on the B-cell therapy. In practice, we have, and this goes to, let's say, the seasonal influenza vaccine or really any other type of vaccine. If it's not a live virus, we simply administer it. What the data has told us with other B-cell therapies, with Rituximab, and there's some data with Ocrelizumab, is that when someone is vaccinated while on a B-cell therapy, they still mount a protective response, but the antibody titer tends to be lower than if they were not on the B-cell therapy. So it's all still, above the clinical threshold, but there is a measurable difference. But we really haven't seen a clinical difference, and so we typically do vaccinate. Now, I will say, many people, when they use a B-cell therapy that's once every 6 months, they'll try to do the vaccine somewhere in the middle between the infusions, not, based on strong data, just sort of that's what they're planning. I think that, to be honest, when we have a monthly B-cell option, we'll probably just put the vaccine again in the middle of that month, but again, not based on strong data. So we don't have clear recommendations or evidence, other than we know that for whatever 30 years of using B-cell therapy across many different indications, patients have been able to be vaccinated against whatever we needed to vaccinate them against. And I don't expect that to be different with these mRNA vaccines like the COVID-19 vaccines.
Very clear. Last question: pregnancy and Ophetumomab. Any data from these trials?
Well, another very important question, but very limited data, especially Ophetumomab, which is new, and as you know, we don't typically do studies intentionally in pregnant women. What we know from other B-cell therapies is, well, we have the official recommendations, which with most B-cell therapies, we recommend not conceiving until 6 months from your last treatment. However, if I'm allowed to say it, as you may know, a lot of research or many people on their own may feel that that's extremely conservative. And some may say, well, even a few months after your last treatment, you could consider it, just based on sort of the dynamics of how rapidly our body clears these antibodies. So again, if I go by the official recommendations, it's always going to be very conservative. What I would kind of comment is that with the other B-cell therapies, which have been around for much longer, let's say Rituximab, thankfully, and I keep my fingers crossed, the data has not suggested that there are great harm to, because human beings accidentally get pregnant sometimes on therapy. So far, things have looked okay. But obviously, we try to be cautious as we always do. And, how fortunate are we that women with MS seem to be protected from their MS during pregnancy? So there's really nothing different with Ophetumomab than really any other B-cell therapy so far.
Sure. We need to go to the next speaker. Thank you, Professor Robert Chen from US, and he's the director of Georgetown Multiple Sclerosis and Neuroimmunology Center. You were with us tonight from Dubai. Thanks to have you again, and hope to see you next year, 2021. Thank you for being with us.
Thank you.
So our next speaker is very close friends of mine, Professor Talib Al-Mansour. Dr. Talib is assistant professor of diagnostic radiology, and he's an intervention neuroradiology. Dr. Talib Al-Mansour is working currently at Faculty of Medicine, UAE University. Dr. Talib Al-Mansour did his training for neuroradiology diagnostic and neurointervention in Canada at McGill University and Ottawa. It's our pleasure to have Dr. Talib with us tonight, who will be with us tonight and tomorrow night to speak about MS Mimics. Tonight and tomorrow he will speak about update criteria for diagnosis MS. Please, Dr. Talib, you can start. مرحبا دكتور طارق.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. I would like to thank the organizers for inviting me today to talk about MRI mimics of multiple sclerosis. So, as I said, today's topic will be about mimickers of multiple sclerosis. The objectives of this lecture is to identify and discuss cases of white matter diseases that can mimic multiple sclerosis. And after that, we can develop a short differential diagnosis of white matter diseases, mainly in adult population, based on the clinical and the MRI brain findings. Okay. As an introduction, radiologists on daily basis, they will encounter many MR findings, especially the white spots. when we encounter such a white spots, we have to think if these white spots on T2 and the flare sequences, do they represent multiple sclerosis or not? And are these spots the result of small vessel disease rather than multiple sclerosis? Or should we think about some other diseases, whether they are uncommon or common ones? To answer these queries that we encounter on a daily basis, we should know that there are many neurological diseases that can mimic MS, both clinically and radiologically. But the most common incidentally found white matter lesions that can mimic multiple sclerosis are of vascular origin. Now, you have to be familiar with what sort of diseases that can possibly mimic the diagnosis of multiple sclerosis, and there is a long list. But to be effective, you have to make that list shorter. This is a busy slide, actually, to represent the findings of 4 patients with different diseases that can mimic MS. I got it from my supervisor in Ottawa, actually, when he was teaching us how to identify multiple sclerosis and differentiate it from other diseases. And actually, he was teasing us whenever he would introduce this slide to us, because basically it's really difficult to identify and pinpoint which is which, unless you have the other images in different planes, and you have to be aware about the presentation of those patients and what was the reason behind having their MRI brain done. Okay, I'm not going to show you the diagnosis of this slide until until the end of this presentation. Okay. First of all, we have to be aware about the typical locations for white matter disease in multiple sclerosis. According to the McDonald's criteria, most of the typical places for MS lesions would be periventricular, as we can see here, along the borders of the ventricles. Juxtacortical or cortical. So if they are cortical, they will be touching the cortex, and juxtacortical will be few millimeters away from the cortex. Okay. Now, the other lesions that can be seen in multiple sclerosis are infratentorial, basically in the brainstem and the cerebellum. Usually in the cerebellum, they are small, in the brainstem, they are small lesions. And in the meantime, you'll find them in all over the brainstem, except for the ventral aspect of it. In the spinal cord, these lesions are usually shorter or short in diameter as compared with other lesions that can mimic MS. Okay, so this is a brief description about the lesions of multiple sclerosis in the brain and the spinal cord. Now, as I said before, the lesions that can mimic, the diseases that can mimic MS are too many, but here today I'm going to describe the most important ones, whether they are, some of them are rare, but they are not uncommon. Actually, I've seen them, so frequently here during my practice. Now, the first case of an adult patient who presented with numbness and weakness of the arms. Okay, so this case was diagnosed to be neuromyelitis optica. Now, neuromyelitis optica is a spectrum disease. For simplicity, we say neuromyelitis optica. In the past, it used to be a variant of MS, but later on it has been described as a disease by itself. So looking at the MRI of the cervical spine, this patient has a long lesion of high signal along the cervical part and the upper part of the thoracic spine, which warranted to examine his brain to check for other lesions and exclude MS. However, he was found to have enlargement of the optic nerves that are enhancing bilaterally, but his brain was free of lesions. So the diagnosis of neuromyelitis optica was entertained, and it was that. Now, briefly talking about neuromyelitis optica, it primarily affects young patients with a mean age of between 32 to 45, and it's predominantly seen in women. And the patient will be presented with acute optic neuritis and longitudinally extensive transverse myelitis as are the most usual manifestations of neuromyelitis, neuromyelitis optica. Now, the most common symptoms would involve ocular pain with severe visual acuity loss, as well as symmetric paraplegia, sensory loss, and bladder dysfunction. But not all patients will present with these symptoms. Now, the current criteria divides neuromyelitis optica into two subtypes according to the seropositivity of aquaporin 4 immunoglobulins G. Okay, so there will be patients with the neuromyelitis optica with positive IgG, or there will be the other set of patients will be with the neuromyelitis optica without the IgG or unknown IgG status. Now, when I say unknown IgG status is when you are working in a place where you don't have this facility, the feasibility, it's not feasible to ask for this kind of test. Okay. Now, the diagnosis of neuromyelitis optica is based on clinical manifestation, serological testing, and MRI. So it's a diagnosis that involves all parameters, not only MRI. Okay. Now, MRI is of great importance in the process of neuromyelitis optica diagnosis, especially among the negative patients of IgG. Now, optic neuritis is commonly bilateral and has a longitudinally extensive lesion along the optic nerve, which mostly will be involving the posterior segment extending to the chiasm and optic tract. Now, the transverse myelitis, which is the long one, extends for at least 3 adjacent vertebral segments and will involve primarily the central gray matter of the spinal cord and over 50% of the cord area, constituting transversely extensive lesions. Unlike multiple sclerosis lesions are very short and are seen posteriorly or laterally. Now, bright spotty lesions with strong hyperintensity on axial T2 weighted images of the spine with higher signal intensity surrounding the cerebrospinal fluid are suggested to be one of the most characteristic CNS MRI features in neuromyelitis optica. Now, cord swelling and irregular enhancement on T1 weighted images can be observed in acute phase. Now, short transverse myelitis can be seen also, but in almost 15% of all NMO. Now, the myelitis is generally located in the central gray matter and is often longer than the spinal lesions in MS. Now, brain lesions. In the past, it was thought patients with neuromyelitis optica won't have any brain lesions. However, it's not uncommon to have lesions in those patients, and has been detected to find lesions in almost 25 to 59% of the patients. Now, the lesions usually are confluent hyperintensity on T2 and the FLAIR images, and they are scattered asymmetrically in the periependymal areas. Now, the ependymal surface of the corpus callosum, the diencephalon, and brainstem involving the area posterima are the key sites for neuromyelitis optica. Now, cortical lesions are incompatible with the neuromyelitis optica. So if you see a cortical lesion in a patient whom you suspect it's a neuromyelitis optica, it's not. It has to be another diagnosis. So case number 2 is about a 17-year-old male patient who presented with confusion. He suffered from laryngitis a few weeks ago. Now, this patient ended up having a CT scan of the brain, which showed multiple areas of hypodensities in the frontal lobe on the left side, the parietal lobe on the left side, and another lesion in the basal ganglia on the right side. So that warranted to do MRI of the brain, which showed multiple hyperintense signal on both T1, T2, and flare sequences. The 3 images I have here are of flare sequence. So we see multiple lesions involving both frontal lobes, as well as the right basal ganglia and the left temporal lobe. On ADC mapping, on DWI and ADC mapping, these lesions are showing restricted diffusion. Now, this is another case of a patient whom was diagnosed with ADEM, acute disseminated encephalomyelitis. Now, not all patients with, the pattern of enhancement in such patients is usually faint, as we can see here. Now, this patient was found to have periventricular white matter changes of a large size compared to MS, which are usually smaller in size. However, if you look at the pattern of enhancement, these, not all of them are enhancing. So, if you look at the posterior one on the right side, involving the right basal ganglia, you barely see enhancement as compared to the one in the front and the other one on the contralateral side, where you see faint enhancement involving the center. Now, ADEM is an immune-mediated inflammatory demyelinating disease, which is classically monophasic, but it may occasionally be recurrent. Now, the exact mechanism is not completely understood, but it was found that many triggers have been the causative for this, the causes for this disease, mainly infection and immunization. Now, it's more common in pediatric age, but it can affect, and it affects male more than females. Now, patients presenting with acute will present with acute or subacute encephalopathy, and these symptoms will range from lethargy to coma, and can be accompanied with other focal or multifocal signs according to the affected site in the brain. Now, MRI will show multiple widespread asymmetric T2 and flare hyperintensity lesions throughout the brain with variable contrast enhancement sign. Now, the most severe form of ADEM is acute hemorrhagic encephalopathy. And in these cases, most of the, usually they are fatal. Moving to the third case, is a 48-year-old male patient with a history of right nasopharyngeal cancer. Was diagnosed in 2003. Following the diagnosis, the patient received radiation therapy along with the chemotherapy. Later in 2007, he presented with dementia. So as a workup here, a CT scan of the brain was done, and these changes were seen. Okay, where we can see areas of hypodensity involving the both middle temporal fossa and the periventricular regions, the temporoparietal lobes, with no enhancement in these areas after contrast administration. MRI was done for the patient and showed white matter changes involving the middle cranial fossa, mainly in the right side, and you can see some, the same pattern of white matter changes here in the right temporal region. Now, back into history, if we look at the patient's MRI previously, we see this mass involving the right fossa Rosemuller, which is consistent with the mass nasopharyngeal tumor. And follow-up MRI shows disappearance of the mass, which was seen in 2003. So putting everything together, these changes are actually related to radiation therapy and has nothing to do with multiple sclerosis or other white matter diseases. However, there were many cases that I know have been misdiagnosed and were called MS, and rather than radiation necrosis, especially when you get referral from a primary healthcare center or a not specialized center. So the brain is exposed to therapeutic radiation, both for treatment and intracranial pathology. And the white matter high signal is actually because of edema and mass effect at the early stage, and there will be loss of volume later on. Now, when you inject those patients with contrast, there might be some enhancement, but at the beginning, actually, later on, this kind of enhancement will disappear. And the pattern of enhancement is usually nodular to curvilinear, or will have this soap bubble or Swiss cheese enhancement. Now, it's very important for radiologists to differentiate between cerebral radiation necrosis and tumoral recurrence, especially at the early stages, because that's very important for the treating oncologist or the treating neurosurgeon to know which is which, so they can plan their treatment ahead. Case number 4 is about a male patient who is 50-year-old who attempted suicide 6 weeks earlier, and then he was treated in the emergency room. Now he's in lockdown, he's locked in. An MRI was done, and he was found to have this white matter changes or this lesion involving the pons. Okay. Now, if you look at the shape of this pons, it looks like a triangular shape or what we call a trident shape. Okay, and it's only seen, I mean, in this case, it was only seen in the pons. So apparently, and it didn't show any enhancement. However, you see the hypointense signal of this lesion on the T1 post-GADO images. Now, this is another case where this lesion can be mimicked with another finding. Now, if you look carefully at this lesion, now this lesion involved the central part of the pons and is sparing the periphery or the borders of the pons, as compared to this one here, which extends all the way to the borders and has restricted diffusion on DWI. Now, the difference between this case and this case is the first one represents an osmotic demyelination syndrome, while the other one is basically an infarction of the pons secondary to basilar artery dissection. Now, if you have a patient whom you think he has an osmotic demyelination syndrome and you do an MRI for him on the same day or 2 days later, you will only be able to detect DWI changes, but you won't be able to see any changes on the T2 or flare sequences. Now, these changes will be found later on, maybe after 2 weeks or 4 weeks. So what role MRI can have in osmotic demyelination syndrome? I mean, if a patient has been diagnosed instantly that he's presenting with osmotic demyelination syndrome, he will be treated as such. And MRI will be done just to confirm that there is a DWI changes rather than T1, T2, or flare changes. Now, to confirm the diagnosis that if you were right or wrong, an MRI will be requested after 4 weeks. I mean, that's debatable, but this is what the literature and what people are practicing. Now, acute demyelination syndrome is related to endothelial damage from rapid shifts in serum osmolality. Now, it's seen in alcoholic, malnourished patients and commonly associated with rapid correction of hyponatremia. Now, other patients with prolonged use of diuretics, liver failure, organ transplantation, particularly liver transplantation with cyclosporine and extensive burns have been also found to have osmotic demyelination syndrome. Now, patients will develop spastic quadriplegia, pseudobulbar palsy, or encephalopathy in association with non-inflammatory demyelination centered within the pons. Now, there are other sites where osmotic demyelination syndrome can occur, mainly in the basal ganglia, the central cerebral white matter, and the peripheral cortex, hippocampi, and lateral geniculate bodies. Now, in this case, in the past, it used to be called the extrapontine myelinosis. Now, if the changes are seen in the pons, it will be called central pontine myelinosis. Now, to avoid this kind of terms, it has been thought to be better to use osmotic demyelination syndrome, where it can imply a central pontine myelinosis or extrapontine myelinosis. Now, extrapontine myelinosis commonly occurs in conjunction with the central pontine myelinosis. However, it may also appear in isolation. Now, the mechanism of myelinosis is not fully understood, and it's linked to intramyelinitic splitting, vacuolization, and rupture of myelin sheath, which is presumably caused by osmotic effect in the setting of correction of sodium levels. Now, this is a case of extrapontine myelinosis involving the basal ganglia, and here in the brainstem as well, and some of the white matter, subcortical white matter. Now, imaging findings typically lag the clinical symptoms, and the images acquired within 1 to 2 weeks after the onset of symptoms show no features of the disease. Now, more recent studies have noted that restricted diffusion, as I mentioned earlier, have been used have been seen in areas of myelinosis as soon as 24 hours after the onset of symptoms. Now, decreased signal intensity throughout the affected area with no mass effect is the classic finding of T1 weighted images. Basically, it's a hypointense signal as compared to the FLAIR and T2. Now, lesions typically do not enhance after administration of contrast, as we saw. Now, the prognosis of osmotic demyelination syndrome varies and has no apparent connection with the clinical features or imaging findings. Now, the fifth case is about a adult patient presented with headache, and he was found to have high signal intensity involving the inferior Olivary nuclei, which is diagnostic for hypertrophic Olivary degeneration. Now, this patient was found to have a cavernoma involving the brainstem. Now, you have to understand how the pathophysiology of this disease. Okay. Now, this is another case where there's which I will talk about the pathophysiology of this disease, which is related to certain anatomy that people should be aware about. Now, this is another case of with a patient who was found to have a hypertrophic Olivary degeneration, secondary to I think a previous infarction involving the midbrain. Now, this is another cause of hypertrophic Olivary degeneration. This is a patient who was found to have a DVA, developmental venous anomaly, going through the dentate nucleus, which affected the inferior Olivary nucleus here. Now, hypertrophic Olivary degeneration is usually caused by a lesion along the dentate rubro-Olivary pathway. The classical clinical presentation consists of palatine myoclonus or incidental imaging findings in asymptomatic patients. Hypertrophic Olivary degeneration is unique type of transsynaptic degeneration because it leads to hypertrophy rather than atrophy. Now, oops, sorry. This is the dentorubro Olivary pathway triangle, which can be called the triangle of Guillemin-Malert, where we have the contralateral dentate nucleus on one side and the ipsilateral red nucleus and the inferior Olivary nucleus on the other side, and they are connected with different fibers. Oops. So this is a cross-sectional images of this triangle. So start with the dentate nucleus, which will send efferent fibers through the superior cerebellar peduncle to the red nucleus on the contralateral side, which eventually send efferent fibers to the inferior Olivary nucleus through the central tegmental tract. In turn, the inferior Olivary nucleus will send the efferent fibers to the dentate nucleus on the contralateral side to the through the inferior cerebellar peduncle. Any disconnection of these fibers, okay, will affect the inferior Olivary nucleus and will cause hypertrophy and signal change, as we saw in FLAIR and T2 images. Now, the MRI characteristics that suggest the diagnosis are high T2 signal intensity confined to the inferior Olivary nucleus with or without enlargement, lack of contrast enhancement or diffusion restriction, presence of an inciting lesion in the ipsilateral brain stem or contralateral brain stem, which will disconnect these fibers. Now, three distinct stages in the development of such entity have been described in MRI. Phase 1, you'll see T2 hyperintensity with no hypertrophy, which will take about, which will develop in the first 6 months. Phase 2, we will see hyperintense T2 signal with hypertrophy, which will appear within 6 months to 3 to 4 years. In phase 3, we will see hyperintensity signal on T2 with hypertrophy, which will resolve, and this signal will be indefinite. Case number 6 is about an adult patient presented with severe headache, and the CT scan was done, which showed faint hypodensity involving the temporo-occipital lobes, and the diagnosis of posterior reversible encephalopathy syndrome was entertained. The acronym is PRESS. MRI of the brain was done, and we saw these changes, symmetrical high T2 and the FLAIR changes with the faint serpiginous enhancement with no restricted diffusion. Same patient. This patient was, another case of a patient who presented with PRESS, where we see high signal intensity on FLAIR images involving the periventricular regions, the frontal lobes, and parietal lobes, as well as the occipital lobes. Now, the key finding about these lesions that they are symmetrical. Okay. Now, the serpiginous enhancement was noted. Now, follow-up MRI after 4 months showed the complete resolution of these changes. So this patient was found to have PRESS. Now, PRESS is a cerebrovascular autoregulatory disorder with many etiologies, but acute hypertension as an underlying component of many was found to be the leading cause of that. Now, characterized by headache, confusion, seizures, and visual loss, and it's associated with the malignant hypertension, eclampsia, especially in pregnant ladies, and some medical treatments like tacrolimus and cyclosporine for patients who are receiving these medications because they are post-transplant patients. Or now, on cross-sectional imaging, the brain typically demonstrates focal regions of symmetric hemispheric edema, mainly in the parietal and occipital lobes, followed by the frontal lobes and inferior temporal occipital junctions, as well as the cerebellum. Now, lesions confluence may develop at the extent of edema increases. Now, MR diffusion was instrumental in establishing and consistently demonstrating that the areas of abnormality represent vasogenic edema, where it won't show any restricted diffusion. Now, it's not uncommon to find hemorrhage in such patient. It has been demonstrated in 15% of the patients. Now, follow-up MRI is warranted to check resolution of these lesions, and residual abnormalities are more common if the brainstem and or deep white matter lesions are involved. The seventh case about a patient who had an MRI to rule out a tumor. Now, this is the most common finding we see on daily basis, and for inexperienced radiologists, sometimes they will call it and describe it, and he won't comment himself. Unfortunately, that will create a big problem for the treating physician as well as the patient himself. I get lots of consultation to rule out MS just because somebody else reported these spots that MS cannot be ruled out. But depending on the age of the patient and other findings, most of these cases will end up being a chronic microangiopathic disease, mainly because of hypertension. Now, this is an extremely common condition related to aging and vascular risk factors.
Dr. Talib, 2 minutes left, please.
Okay. Now, another manifestation of a small vessel disease is brain atrophy, and best evaluated on axial T2 images. Now, for the sake of time, I will go quickly over the cases I have here. Now, this is how we differentiate between MS lesions and chronic microangiopathic disease in the brainstem. Usually, these lesions will show a high T2 signal that is broad compared to small lesions in the brainstem. Another mimicker is CADASIL, where you see periventricular subcortical white matter changes. But the most important thing is to have these changes involving the anterior temporal regions. Now, it's a cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. It's a hereditary small artery vasculopathy and mutations in the Notch3 gene on chromosome 19. Now, those patients will present with TIA, strokes, progressive subcortical dementia, migraine with aura, and mood disturbances. Okay. Usually, death will follow at an age of 55 to 65 years after mean disease duration of 20 years after being discovered in late 30s or early 40s. Okay. Now, another mimicker is Behçet disease. Behçet disease lesions will involve the brainstem mainly, and this is the kind of enhancement that we'll have. It's faint ring enhancement, which is unseen, not seen basically in MS in this pattern. It's a disease of chronic relapsing inflammatory vascular disease of not fully unknown pathogenesis. Okay. I wouldn't go through this description. Now, another mimicker is Susak disease or Susak syndrome. Most of the lesions will be seen in the mid aspect of the corpus callosum, as compared to MS, where it involves the callosociptal regions. Usually, these, in this syndrome, the enhancement will be leptomeningeal. Okay. Okay. Now, this is the difference between the lesions of the corpus callosum in Susak syndrome and MS. Okay. The last case is about a patient with adrenoleukodystrophy with adult onset, which can mimic also multiple sclerosis. Okay. Thank you very much. And this is the first sorry.
Thank you, Dr. Taleb. Jazakallah khair. It's our pleasure to go through these cases channel from different demyelinating pathology. You came across relapsing remitting like MS and Dybbuk disease. Then we have monophasic like the ADEM that you spoke about. Then we have the vasculopathy like Susak and Cadasel, and with the metabolic one like the brainstem lesions that the patients can have. Thank you again. Few questions, Dr. Talib came here. Spinal lesion always is a challenge, mainly in the MS patient. Which sequence do you advise to see for these patients?
So usually T2, okay, T2 sequence, and there is a special sequence called the MEDIC. I used to go through the MEDIC sequence when I was doing my training, but when in my real practice right now, most of the cases I'm checking for MS, I check the T2 sequence.
Clear. I remember when we were during our residency program, we used to have the protein density sequence where they were saying it's more sensitive than a flare because of the edema that a flare is giving you. Is that correct? And are you using still protein density or no more?
Yeah, we use a proton density. We do use it, but it depends on the protocol each radiologist is comfortable with, and there has to be a consensus actually with the neurologist who's taking care of those patients.
Okay, I have few questions that has been directed to Professor Chen, who left us. One of them is regarding the side effect of the new medication, the B cell that he spoke about, Ophetumomab. Just to answer that one, still we don't have this medication in UAE. The trials which has been published in New England journals that I encourage everyone to go and read it was published in mid of August this year. So it's almost less than 4 months. I remember it's 21st of August has been published. So a very new medication, very new drugs in the field. So the main side effect which has been mentioned in that trials was mainly mild upper respiratory tract infection, headache, and local injection site reaction. Also UTI and back pain, one of the side effects that these patients will give. No major side effect compared to Obagio, which has been used in this medication. Something which I would like to mention here, it's regarding if the patient's hepatitis B virus carrier, it's contraindication to use this drug on these patients. One of the questions was regarding if there's any preparation that we need to do before starting this new B-cell treatment, from also the literature and what Professor Chen said, there's no pre-medication that we usually do with Rituximab, but the first dose need to be given under medical supervision. I will go back to Dr. Taleb. Dr. Taleb, how frequent you will see ADEMs with an enhancement lesion?
Okay. I'm not quite sure, to be honest, but it's I think uh, I'm not sure about the percentage of.
Do you see it frequent, or it's rare to see enhanced lesion with ADEM, because the pathophysiology is different from regular
Yeah,
demyelinating?
well, there's a rule of thumb: never say never. It can enhance or not. Okay, I've never seen cases where ADEM lesions enhanced, but I don't know if there is any cases that can show enhancement.
Clear, clear. Another question, Dr. Taleb. Why do we see some MS lesion? Our protocol in the region that we do all the sequence, including DWI for brain imaging. So we will see some MS restricted lesion on the DWI. Why is that?
Well, it has been postulated that if you see a restricted lesion, it means that this lesion is active.
Okay.
Okay. The same thing with enhancement. I mean, if you have a patient who's known to have MS, okay, and you do an MRI of the brain, let's say today, okay, and you compare it to his MRI, which was done a couple of months ago, as a fall, to compare it with. Now you'll see variability of enhancement for in a lesion that used to be enhanced in the past, but now on today's examination it's not enhancing. There's another lesion is enhancing. That means that lesion, which used to be enhancing in the past, is not and not enhancing today's
Hmm.
exam. It means it's not active. However, a new lesion is active. The same thing will appear on DWI. The newly enhancing lesion may show restricted diffusion and will indicate acute activity.
Mhm. There's a question which is not clear for me here, Dr. Talib. Maybe you can answer that one. Which is the best radiological modality we should looking when we are doing a diagnosis MS? Maybe that tomorrow will be your talk regarding which sequence and cut to be used for MS diagnosis criteria. Are you covering that tomorrow?
Yeah, I mean, the best modality is actually MRI, but at the end of the day, McDonald's criteria has added, CSF analysis.
Okay.
So it's not only radiological diagnosis, it's also a clinical and lab diagnosis. Now, CT scan is out of the question.
Hmm.
We don't use it. Now, when it comes to the sequences, basically it's a T2 sequence and the proton density, and there are some other special sequences. I'll be talking about them tomorrow, inshallah.
Excellent. Just to answer the last two questions for Professor Chen, criteria for Ophetumomab use, still it's a new medication. I will advise to go through the paper which I mentioned, the New England Journals paper, which came on the 21st of August, 2020. Second question is regarding comparing this new medication, B-cell therapy, with other oral treatment. It's very difficult to do this. We have only this trial which came around 2,000 patients with Ubagio, which showed in their summary saying among patients with multiple sclerosis, Ophetumomab was associated with lower relapse rate annual compared to Ubagio. That's what I can say here. Dr. Talib, anything at the end?
Not really, but I mean, it's very important to have a consensus between a neurologist and radiologist, regardless whether they are neuroradiologist or general radiologist, because at the end of the day, we are working for the sake of patient.
Okay.
People shouldn't be working in silos. So, I mean, such a question whether what sequence we should be using, I mean, it has to be, agreed on between both parties, rather than dictating what to do or what not to do.
Clear. At the end, I would like to thanks Dr. Talib Al-Mansour, Associated Professor from UAE University, diagnostic radiologist and neurointerventionist. Also, I would like to thank Professor Chen, Robert Chen, who left us from USA and gave a presentation about a new hope for MS patients with a new treatment. And I would like to thank Novartis for supporting this meeting and our organizer, MCO. Hope to see you tomorrow at 8 p.m. Dubai time. Wish you a great time. Thank you, Dr. Talib. Assalamu alaikum.